Hello, good morning, good afternoon, good evening, folks, wherever you're chiming in from. Thank you so much for joining us today. Today's webinar will be on diabetes prevention for patients of color at community health centers. Before we get started, some quick Zoom housekeeping. If you like to speak up during this webinar, feel free to unmute your microphone in the bottom left-hand corner. To turn on your video or turn it off, you can click on Start Video. And as you can see in this webinar today, we have closed captioning. If you'd like to change any settings or turn it off, please click Live Transcript. And this will also be a very interactive webinar with polls. So if you have any questions or thoughts, feel free to put in the Q&A, raise hand and chat function, which I'll talk about more in detail. So the chat function is primarily for any casual conversations, or if you have any technical issues, you can directly chat one of us. And then the Q&A section is more for the content side of the webinar. So if you have any specific questions, please feel free to type it in the Q&A box. And with the Q&A box, you can also upvote questions that you also think are interesting. We'll make sure to either read it out loud and answer it live, or respond to it within this Q&A box as well. If you'd like to speak up also after the webinar, feel free to raise your hand and we can call on you as well. And then some keyboard shortcuts for everything. Video on and off is Alt-V for Windows, Command-Shift-V for Mac. Mute, unmute is Alt-A for Windows, Command-Shift-A for Mac. Raising and lowering your hand is Alt-Y for Windows and Option-Y for Mac. And then once the webinar is completed, we ask you to participate in a very short survey to see how we went. This helps us improve our training and technical assistance. So once again, thank you so much ahead of time for filling it out. And our moderators today are Albert Asen Jr. and me, Sakura Miyazaki, from the Association of Asian Pacific Community Health Organizations for AAPCHO. I'll be moderating and Albert will be doing a lot of behind the scenes stuff. And with the National Nurse-Led Care Consortium, we have Emily and Lauren Rockoff. Lauren will be doing the technical stuff. So if you remember prior to directly chat someone, if you're having technical issues, please feel free to contact Lauren. And our wonderful panelists today is Dr. Deborah Washington from the Massachusetts General Hospital and Dr. Nathan Tan from Kalihi Valley Comprehensive Family Services. And a quick bio about them. So Dr. Washington is the current DEI Health and Community Partnership Manager at Massachusetts General Hospital. The focus of our work is engagement of community-based leaders in a programmatic approach to resolve health inequities that affect Black, Indigenous people of color, or BIPOC for short, communities in Metro Boston. She's an adjunct faculty at Emmanuel College School of Nursing, where she teaches a course on care of vulnerable populations. And Dr. Tan is an Associate Clinical Director at Kalihi Valley Comprehensive Family Services from Hawaii and has over 20 years of experience delivering primary care in Pacific Island communities, including providing services in the western edge of the Pacific on the island of Saipan, Commonwealth of Northern Mariana Islands. Since 2012, Dr. Tan has worked at KKV and at Fqhc located in Kalihi, a neighborhood of Honolulu, which serves a primarily Asian and Pacific Island patient base. So please welcome Dr. Washington and Dr. Tan. Thank you. And then our three primary learning objectives today is to, one, increase knowledge regarding the health challenges and disparities for patients of color with respect to diabetes and prediabetes, which Dr. Washington will focus on. And two, to identify culturally and linguistically responsive quality improvement strategies that influence health behaviors and health-seeking practices among patients of color in diabetes prevention. And Dr. Tan will go over his clinical practices. And then lastly, to foster discussion regarding QI strategies and resources that target patients of color with prediabetes. So the first hour will be mostly content, and then the last 30 minutes of our webinar will be Q&A section. But also feel free to chime in within the chat box or Q&A box if you have any thoughts or questions. And based on this, our agenda currently is our introduction section, and then Dr. Washington's overview of racism, inequity, and health, and voice from the field at KKV with Dr. Tan, and then we'll close again with our Q&A. And with that, I would like to pass it on to Dr. Washington to share her section of the presentation.
Thank you so much. And colleagues, I apologize for not having my live face before you. I'm having computer difficulties. We tried, but couldn't overcome the problems. And my office looks like a patient's room after a code, if that gives you any idea of the effort we put into this. But our conversation is more important than any computer glitch. So let's get into it. My goal for this presentation is for all of us to have time together to face up to questions about race and racism in healthcare. On the next slide, I want to make the point that we are a nation that is multicultural, multilingual, and multi-ethnic. But there is a problem, a disturbing problem with that reality. The reality is that although we are many groups of people, we do not all have the same quality of care and the same level of good outcomes from our healthcare system based upon our racial identity. We may all go into the healthcare system and come out of it with differential outcomes based on race, based on grouping. The question becomes why? Next slide. I use this particular graphic to make a very important point. A lot of people don't want to talk about race and racism in healthcare. One of the reasons why we can't get at solving the problem is that people are so defended against the idea. And I use this slide to make the point that perspective on the problem is critically important in our ability to hear another person's perspective. And in this picture, you should see two figures. One of the figures you can see if you followed on the right-hand side of the tree, the outline of a face. And as you go to the bottom of the tree, you'll see a chin of a face. And if you continue on around, you'll see the oval outline of a face. You can see the eyes as you look at the buildings in the back. But that's not the only picture there. There is also a woman who is dressed in a fur coat. If you look at the nose of the face, you'll see the fur coat, the bottom of the fur coat, there is the bottom of a white dress. And as you continue down under the bottom of the white dress, you'll see some cobblestones and the woman's feet as she's walking across the cobblestones. My point with this is that when we try to problem solve the presence of race and racism in healthcare, we need to be able to allow our different perspectives on the problem. There is no either or approach to talking about race and racism. It's too complex for that. On the next slide, I repeat that point in terms of part of the way race and racism is embedded in the system is that it gets lost. The details of it get lost in the big picture. The systemic racism hides in plain sight. What our job is to take a look at the details. And that's what the little figures on the sidebar of this picture is supposed to indicate. That if you can find the domino in the big picture, if you can find the boomerang in the big picture, that is a metaphor for how we need to look for the details of racism and its presentation in healthcare. On the next slide. The part about health disparities, health inequities, and looking at the big picture is that we need to figure out how systemic racism manifests in healthcare. And this picture demonstrates the idea that we don't all have an equal on par way of being able to have access to services and treatment and how we interact with the system to make the point about whether or not we're being equally treated. So how do we solve this problem of being able to at least point out the disparities in healthcare treatment? On the next slide. I use a little Venn diagram to indicate that the individual interacts with the system, and there is an intersection where we find deviations. And this section of deviation is where we need to explore and investigate why these deviations happen. We know that they are present because the literature is filled with scientific studies about unequal treatment, health disparities, and poorer outcomes based upon racial groups. And we need to push in new directions in terms of being to figure out why this is the case. On the next slide. That deviation and possible explanations for it and how we might go about recognizing it and bringing it forward in conversation is what I'm hoping we'll be able to uncover as I take us further along in my presentation. But bottom line, my point is we need to crack this code of what's behind these deviations in care and outcomes. Next slide. This conversation about health disparities and health inequities is a very old story. I bet a lot of you remember back in 2002 when the Institute of Medicine report on unequal treatment confronting racial and ethnic disparities was published. We are not talking about anything new in terms of inequities in healthcare based on race. What has changed, and I hope you agree with me, is that the conversation is coming around again because of COVID and because of the death of George Floyd. Those situations around social justice brought this conversation back into the headlines. Now people are talking about being woke. This is an example of the former mayor of Boston who demonstrated how woke he was when he got in the local papers by declaring that racism is a public health crisis. Next slide. So in order to focus our conversation and our thinking, I chose to use this definition from the World Health Organization about the social determinants of health. The social determinants of health is a way for us to think about how health is more than genetics, that health depends upon where we are born, where we live and develop, where we grow up, where we work, and where we age. And all of those are dependent upon larger social factors. Next page. In getting more involved with community health because of COVID, became more familiar with this concept of a syndemic versus a pandemic. And you can see the definitions there comparing the two concepts. Bottom line, a syndemic is a concept that takes into account the impact that the social determinants of health have on the health status of individuals, particularly when we're talking about vulnerable groups. So this next slide is a little poll that I'd like you to take. And it simply asks whether, according to the definition that you just saw, you believe that COVID is a syndemic more than a pandemic. And please indicate whether or not you agree or disagree with that statement.
Thanks, Dr. Washington. The poll is live now, and we're going to give about 30 seconds for folks to answer.
Wow. Okay. I can't wait in our Q&A session to hear the thinking behind these votes. Thank you very much. On the next slide. So going into details like I did in the other graphic with the big picture versus looking for the details in the big picture. I think I may be, yes, I need to close this out on my screen. There we go. Here are the specifics that define the social determinants of health. And this list comes from the Boston Public Health Commission here in Boston. None of this, I'm assuming, surprises any of you, but it pays to be explicit about the contents of our conversation. And when you think about diabetes and the social determinants of health, access to health care, the disproportionate effect of any of these on our ability to manage diabetes, I wonder how you would knit together these social determinants of health with the challenges that your patients face who are diabetic. On the next slide, this whole idea of being able to, in our problem solving, to actually articulate that race needs to be part of the conversation is to make the point that we can't afford to ignore it. That's why we've been publishing all kinds of reports, as I said, since 2002, and very little has changed in terms of having made a difference to patients and our families. On the next slide, it's a slide that I use in terms of my own work as a diversity, equity, and inclusion officer. The social landscape is so vast and the details are so buried, they are invisible. And as an advocate, I feel sometimes like I'm shadowboxing with some of these variables and trying to make a point about their existence and how they need to be addressed when I'm talking about these things with people who have decision-making power. On the next slide. These long-standing issues of disparities are exactly that, long-standing. The social determinants of health took time to build into the system. I use these bullet points as a way of making that case, that the ability to build wealth began back in the early 30s in terms of whether or not people had access to Social Security. And there were some groups that were excluded. These people would be called essential workers. The building of wealth was based upon being a homeowner, and there were policies and procedures at the federal level that kept African Americans, for example, from easily being able to purchase a home. There was a national narrative around how the presence of African Americans affected, what's the phrase I'm looking for, neighborhood home values. And the idea of being able to get an education as a way to become socially mobile and get a better way of life was also compromised. So these social determinants of health did not happen overnight. And if you take a look at this next slide, my point is that they didn't happen by chance. So this whole idea of the social determinants of health and where you can buy property and where you can live, I use this graphic that was produced in Boston by our public transportation department. I used to use it to indicate census, but now I use it more to show how the social determinants of where you can live and where you can afford to buy end up with racial groups being clustered. In this graphic, the blue color indicates the white population in Metro Boston. The orange indicates the Black population and where we live. The green indicates where the Hispanic population lives, and the pink indicates where the Asian population lives. I find it hard to believe that this happened by chance, but that's my opinion. On the next slide is further detail about what constitutes the social determinants of health in terms of education and its impact, residential segregation. If the town where you live in is like Boston, if I name the neighborhood, everybody knows what population lives there. Next slide. Once again, how the social determinants of health and racism and segregation and clustering of populations end up in health disparities. This is also a graphic that uses our public transportation system, which is color-coded, the green line, the red line, the orange line if you travel by train, and the silver line if you travel by bus. As you go along these stops, Arlington, Fenway, Mattapan, you're in the neighborhood of specific racial groups. Mattapan is heavily African-American. Dudley is heavily African-American. Around Maverick, you'll see an increase in the Hispanic population. Fenway, mostly white. Arlington, a mixed bag pretty much. But take a look at this in terms of T-stop and socioeconomic status. On the next graphic, here are T-stops and where diabetes is prevalent. And remember, Mattapan, Black, Dudley, Black, Maverick, Hispanic, Fenway white, Arlington white. The next graphic shows that these communities are not that far apart, a couple of miles at the most, and yet the disparities. The next graphic shows the same thing and also shows where COVID hit hardest. The message is the same. If you're vulnerable because of the social determinants of health, your health status is going to be compromised. The next slide sends the same message more succinctly. Back Bay is wealthy and white, and you can live to be 90. Roxbury is Black and lower middle class, and you can live to be 59 as your average length of life. 5 miles apart. Next slide. How does this happen? And do you believe it happens by chance? What's your perspective? Next slide. Dr. Camera Jones gave us a really powerful way of thinking about categories of racism, if I might be able to describe it that way. In her paper, she speaks about systemic racism, the larger social structure, institutional racism, how things operate in the places where we work or the places that are constructed to be of service to us, and personally mediated racism, which is the interpersonal interactions that we have with one another. The next slide. You're probably not going to be able to read this, but I included it anyway because it makes a point about this whole notion of the class standards. When I first began my work, and maybe books like this are still out there, books were published around here's what you need to know to take care of the Black patient. Here's what you need to know to take care of the Hispanic patient. And it described cultural values, belief systems, attitudes toward health, and so forth and so on. Well, the Smithsonian, one of the Smithsonian museums tried to do the same thing as a way of describing white culture. And there was such pushback and blowback on how dare they categorize white culture in this way, that this guide, as the museum called it, had to be removed. But I put it forward once again in terms of when we think about the soup, if you will, of how we live, where we live, how the larger society was created, do we believe that these values are a backdrop to how people are evaluated around, are they interested in self-care? Are they able to take advantage of a job opportunity? Are they capable of being able to fit in quotes? Where do those comparisons and the information that inform those comparisons come from? I would submit to you that it is, the answer is based in the whole notion of how we categorize white culture. That's the standard. Next slide. One of the other things that has come out in a very powerful way is the idea of race-based medicine in this current time in which we now live. What you have here is the results of a survey that was done in 2016 and published in the Proceedings of the National Academy of Sciences. Now, 2016, this survey was about talking with medical students and residents about whether or not any of these bullet points were things that they believed to be true. And 12% of 222 medical students believe that some of these statements were true. 2016, we should be beyond the kinds of thinking that informed the Tuskegee experiment and allowed it to go on for decades, right? The next slide, race and medicine. These bullet points come from Proceedings of the National Academy of Sciences. And once again, the whole notion of boxing with shadows. How do you extract this kind of thinking, this kind of information out of the way we make clinical decisions and do diagnostic testing? Spirometry has algorithms around it in terms of how you use the information provided by it, adding points or detracting points based upon the ethnicity of the person who's using the instrument. This is all race-based medicine. Next slide. So how does this remain in place, this thinking, these values and beliefs? This little picture is an example of an answer to that question. What does it say to you in terms of the message about climate change and whether or not somebody is going to participate in having an effect in that kind of initiative? This guy is shadowboxing with some ideas and concepts I would submit to you. And I'll give you a psychological term for the issues that are depicted in this graphic. On the next slide first, I want to make sure that we talk about one category of racism that is tied in with institutional racism and systemic racism. That's the personally mediated racism, the interpersonal racism that can happen in terms of one-on-one relationships, acts of commission, acts of omission. This also needs to be addressed in organizations and in our education and in our professional practice. On the next slide, the psychological term that is covered by that little graphic is cognitive dissonance. Key to what we're trying to come up with by investigating and asking questions about the presence of systemic racism is, why do people who consider themselves not racist not recognize a racist encounter or a racist comment or racist thinking? Why doesn't it raise red flags for them when it does for somebody like me who is a woman of color? It easily resonates for me. It is normalized, if I can use that word, these behaviors, because it's aligned with policies and procedures that we follow and that we don't question. That if there are a range of choices in terms of treatment options or the way we do care planning, then you can do a high level intervention, or you can do a level of intervention that is still good, but it may be at a lower level for a particular patient population. And if there is no one from a diverse background to raise the red flag, then nobody's decision or comment is challenged, and it goes unaddressed. On this next poll, I'd like to get your opinion on this statement. One key to dismantling racism is to create cognitive dissonance. What do you think?
Thank you, folks. The poll is live. We're going to give about 30 seconds again for everyone to respond.
Fantastic. I can't wait to talk with everybody. Superb. Thank you. And I'm just going to do a quick awareness raising for points of discussion through these next slides as I come to the end of my comments. We obviously need to address issues of cost when we're talking about healthcare disparities and the impact of those things as a social determinant of health. On the next slide, when we talk about a person's ability to do, using diabetes as an example, diabetic self-management, what are our expectations of patients and what are we taking into account as we do this assessment about whether or not somebody is going to, quote, adhere or, quote, be compliant. We can talk about that in terms of your own personal experiences. And on the next slide, personal experience of my own, diabetes runs in my family, and I used to purchase supplies from Amazon for members of my family who are not as financially well off as I'd like them to be. And I ran across this problem one day when I went on Amazon to order some needles for the Lantus syringe. I could no longer purchase them because of a policy, because of a decision that was made politically around the whole notion of, are these needles a medicine or are they medical equipment? Next slide. The cost of Lantus, $70 to $80. Where are people going to get out-of-pocket money to be able to pay for things that are not covered by insurance? One issue that comes up is whether or not, because of insurance and cost, people of color have access to the latest medications. Next slide. I invite you to read, please read this article because it pulls together all of the social determinants of health and its impact on African Americans in the South. And it is profound in terms of the aha moments that it provides. I think we give you a link to that as a resource. Next slide. Simply gives you a picture of the man whose story is told in that that publication, that article, and how he ended up in this wheelchair and the quality of care he received. The next slide also depicts the most profound aha moment I had from that article, where one of the Black physicians who's a primary player in the previous man's story noticed when he went to a museum the average annual amputations in the United States. And he overlaid that with the percentage of the population that was enslaved in 1860, and they were closely aligned. What kind of concerns does that raise? Do you think about systemic racism? Next slide. So a complex issue with many factors that need to be considered in terms of the big picture and in terms of the details that underpin that big picture, and basically what is embedded in the system that needs to be extracted and objectified so that we can investigate it. Next slide. I invite you to think about, how do we operationalize the concept of race or racism so that we can open it up for examination within our areas of practice, within our region of the country, because not everybody can talk about these issues and grapple with these issues in exactly the same way. What I can say in Mississippi and Louisiana, I might be able to better say and more powerfully say in Boston, Massachusetts. I grew up in Louisiana. But don't lose all hope. My organization has been addressing issues of systemic racism for quite some time. And just in time for this presentation today, we received an email notice about a change in practice that my organization is making in terms of race-based medicine. And the message reads, in June 2020, my organization removed race from the calculation for estimated glomerular filtration rate, which measures, as you know, kidney function, to promote more equitable care for Black patients. The reasoning stated was that race in these calculations is a socially based construct rather than a biologically based one. So it is possible to make change. And my last slide. A single individual cannot make a difference. It takes a group. It takes a large number of voices raised around the same issue at the same time. We need to depersonalize the conversation so that we can find some safe space and room to talk about it in a very reality-based way. We need to be able to objectify what is systemic racism. And bottom line for me, as a clinician of color, I say to you that it is past time that we all get woke. So thank you very much, and I'll turn it back over to our moderator.
Thank you so much, Dr. Washington, of how much content you're able to cover in less than 30 minutes. I do want folks to put in any questions you have in the chat. I do see one question from Shannon. Dr. Washington, if you could answer this very quickly. Any recommendations on books to read regarding this issue and solutions in healthcare?
Oh, books to read. Let me give some thought to that, and I'll tell you why I'm hesitating. For me, my source of information is to observe what happens in my practice. That's the real deal. When I'm reading a book, I'm getting somebody else's observations and somebody else's interpretations, and I'm not sure about the quality of their observations and interpretations. But I promise you, I will send a title to the moderators and at least get you started. And thank you so much for your interest.
Thank you, Dr. Washington. We also did share the amputation article from ProPublica, and then we will also have a follow-up email. So if Dr. Washington has any additional readings to have, we will include that as well. And now I want to pass it over to Dr. Tan, who will share his presentation for his health center. Thank you.
Hi, thank you. Can everybody hear me?
Yep, sound great.
Great, thank you. Let me, all right, let me start my video here, and bear with me one moment while I get set up here, okay? First, I just wanted to thank Dr. Washington and thank everybody for allowing me to be here. I'm Nathan Tan, and I'm basically a practicing primary care doctor at Kalihi Valley. I've been there the past 10 years, and wanted to talk a little bit about our efforts around diabetes and diabetes prevention. And so first thing I just wanted to kind of get a sense of is how many of the audience, people in the audience, are working at community health centers. How many are in the front lines working alongside us? You can go ahead and answer that question.
Again, the poll will be live for 30 seconds.
All right, great, thank you. So, you know, I wanted to go through a couple of things. You know, the focus is to talk about how we work towards preventing diabetes in our community. I'm going to start with just talking a little bit about the community that we serve, where we work in. I'll talk briefly about the health center, and then I'm going to go through a little bit about our diabetes prevention efforts. So Kalihi Valley Comprehensive Health Services, we're FQHC, we're located.
Should we see your screen? Sorry.
Oh, I'm sorry, can you not see it? My bad. Hang on one moment.
I can also share as well, so let me know.
All right, how's that? Can you see that?
Looks great.
My apologies. Okay, so let's take it back here. So I'm going to talk about preventing diabetes, a community health approach, how we work around diabetes prevention at Kalihi Valley. And so KKV is a Fqhc. We're located on the island of Oahu. This is, we serve primarily the Kalihi Valley, which is a neighborhood of Honolulu, kind of on the western outskirts of Honolulu. The valley is it's a valley from of the Ko'olau Mountains, and it runs down from the mountain down to the harbor. Just a little bit about the background about the valley. In Hawaiian legend, we're all familiar with Pele, the goddess of the volcanoes and fire. Kalihi Valley was the home to Pele's sister, the goddess of fertility, grit, resilience. Also home to Pele's mom, Haumea, also a goddess of fertility and also childbirth. Back, 150, 200 years ago, Kalihi Valley was known for health and for abundance. It was a place of fertility, as as legend, as indicated by Hawaiian folklore. But it is a place where people lived off the land, they ate off the land, and they lived a pretty traditional and healthy lifestyle. Where the valley met the ocean, there were many fish ponds, and fish ponds that were very productive, that supported large communities in the valley and in the surrounding areas. And this middle picture here is the view in 1836. Quite a different picture than you'd see today, but pretty profound. So historically, well, just a step back, Kalihi, the name of Kalihi, it means the edge or place of transition. And you can see that in Kalihi's history. So, at one point it was a place of an important crossroad, an air crossroad. So, it was a seaplane port back in the 1940s. When Pearl Harbor became crowded during the war, they shifted a lot of the operations over to the, Kehi Lagoon, which sits down at the bottom of the valley, right over there. And right to the western edge of Kalihi Valley sits Honolulu International Airport. So many of you who may have traveled to Honolulu, you can see the valley off in the distance there. It's an important crossroads for the island in terms of land transportation. So at least 3 major highways run through it, 2 interstates, an interstate and 2 state highways. And it's also an important sea crossroad. So the main shipping terminal for Honolulu and pretty much, and for the state as well, the Honolulu shipping terminal sits on Sand Island, and to access it, the main road goes right through Kalihi. And so, there is a lot of businesses and commercial space that has sprouted up around that. So currently, so that was just to set a little bit of background about Kalihi. Current day Kalihi is a mix of residential neighborhoods. It's a residential neighborhood. There's a lot of commercial activity that goes on, and it's a lot of government use as well for the valley. So it's probably one of the largest concentrations of public housing for the island and the state, generally speaking. It's becoming again another transit hub. So the rail, the new rail that's being built is there'll be a large transit hub located in Kalihi too as well. It has the largest jail in the state, Oahu Community Correctional Center, and Also historically, an interesting note, it was a place, Hansen's disease patient, there was a hospital for mild cases and also an isolation facility for patients transiting to Molokai. And currently there's about 52,000 people that live in Kalihi Valley. Here's some information from the 2019 American Community Survey, some census data. So Kalihi, kind of a reflection of that crossroads for the island, for Honolulu. We have a lot of folks that are born outside of the United States. So about a third of our patients are born in countries in the Asian Pacific region there. Primarily, we have a large and growing group of patients from Micronesia. And then also historically, we have a lot of patients from the Philippines and Samoa. Reflecting that, I would say, reflecting that immigrant group, in the households in Kalihi, about a third or a half of the households, there's another language besides English being spoken as a primary language, and that typically is an Asian or Pacific Island language. In the clinic, we see a lot of patients from Micronesia, from Chuk State is the largest and growing group, and many of them speak Chuk exclusively or as their primary language or preferred language. I just wanted to spend a little bit of time talking about the regions of where our patients come from. So again, our largest group of patients are coming from Micronesia. It's a large and growing group for the community that we serve. And just wanted to kind of touch briefly upon that. But before I did, I wanted to get a sense of how many people in the audience are taking care of patients from the Pacific or Pacific Island nations. And maybe there's a poll on that one. If you could share that poll, that would be great. Thank you.
Thank you folks for responding. We have about 10 more seconds on the poll.
Thank you. That's great. So Micronesia is a fairly large geographic region, and it's a pretty diverse and dynamic region. But we have patients that come from some pretty rural areas of Micronesia, where where a traditional lifestyle is not uncommon to see some of the lifestyle that you might imagine, or what we know that life might have been like back in Kalihi Valley maybe 200 years ago. This is a picture from one of the atolls, a sailing canoe, folks getting around there. Again, traditional modes of transportation, not uncommon to see, and knowledge around sailing. You may oftentimes see it. This is a photo from the Marshall Islands. And again, in terms of lifestyle, a much easier mode, or excuse me, a lifestyle that's much more conducive towards diabetes prevention. Not uncommon to see in Micronesia, in many parts of Micronesia. And even in some of the remotest atolls, you will see touches of modern life despite the remoteness. Ships coming to collect coconuts, the copra trade, and you'll see evidence of the modern life, and get suggestions, get an idea of how the impact of modern life might impact the health of the residents. You see a can of, you'll see Macy's cans of Spam, bags of rice in some of the really remotest parts, and primarily because these are things that are easily stored and transported, and not necessarily with the thought of health in mind. And these are places that are not, some of these places are, you know, despite being places where there's very traditional lifestyle use, you know, these are places that are not new to the Western world or to the modern world. I think that, you know, in terms of out in Guam and Saipan, the first contact was with the Western world was about 1590. So I want to go back to just Kalihi and its residents. So I was just to kind of give you a background of some of the areas where patients come from that we serve. In terms of Kalihi, you know, generally it's a working class neighborhood. A lot of our top 3 sectors where people work will be hospitality, retail, and healthcare. Many patients that work in hotels, maybe cleaning the hotel rooms, working at the front desk. They're working in convenience stores. They're working in fast food establishments. Many of them work as caregivers, nursing assistants, nurses. There's a great diversity of where our patients that we see in the health center. Generally speaking, Kalihi is a lower income area. The average, you know, income that a person makes in Kalihi is about, you know, 3/4 of what an average person might make in Honolulu. Many of our patients work multiple jobs, and you know, but despite that, you know, they kind of all pull together. They'll live in multi-generational homes and pull together and make ends meet. And just another word about work in Kalihi. You know, generally speaking, it's a lower income neighborhood, but it produces some pretty amazing people. You know, one of our governors from the state of Hawaii is from Kalihi. It produces, you know, generals, doctors, university professors. So it's a place that can produce some amazing people, and you can see that in our clinic. So just to kind of touch briefly about diabetes and the burden of diabetes that our residents and our patients face, and the residents of Kalihi face. We see a really high rate of diabetes in the clinic. It is overwhelming at times. And you know, I think about that picture that Dr. Washington showed about the amputation. You know, this is that view, that picture of somebody with an amputation. It's not, yeah, unfortunately, it's not something that we're not unfamiliar with in Kalihi. It is it's one of the scourges. It's the modern scourge for the valley. So we have a high rate of Asian and Pacific Islanders that we take care of, and the rates of diabetes are the burden that this community faces is unfortunately very high. For our Asians. So this is some data from the National Health Interview Survey from 2018. You know, Asians generally speaking have a higher rate of diabetes compared to their white the white population. And you know, for our Native Hawaiian and Pacific Islanders, the rate of diabetes is 2.5 times the rate of the cases of diabetes diagnosed in non-white Hispanics. Or excuse me, non-Hispanic whites. And just, you know, my experience in the clinic is that for Pacific Islanders, they seem to have a very high rate of diabetes and really suffer disproportionately, not only of diabetes, but its worst outcomes. Yeah. And this is just another graphic from 2017, or from the CDC from 2017, showing the rates of diabetes in the Pacific Islanders, even higher than that in the Native Hawaiian population. Unfortunately, diabetes, as it is probably in many places or across the United States, is a rising problem for the state of Hawaii. Trend lines do not look good, and we're hoping to try to bend the curve on this. So we'll talk briefly about this, but I think Dr. Washington spoke nicely about some of the issues that contribute to health. You saw a lot of discussion about social determinants of health, but we see a lot of this in the community that we serve. The things that contribute to these high rates, generally our patients live with modest means, and so it makes, it can make it very hard to access healthy foods. Their ability to afford foods that are healthy, to get to the grocery stores, are very difficult. And there's oftentimes limited space for patients to exercise. It's a pretty, the Valley generally, or Honolulu and Hawaii in general, the cost of housing, the cost of open space is very high. And so all the available space is usually utilized for housing. And so you don't see a lot of open space in the neighborhood. I think the other contributing factor is, the ills that we see from poverty, so finding a safe space is also a concern for many of our residents that worry about their safety when they go out to exercise. I wanted to just put in words, let's see, okay. I'm going to share a little bit about, I'm going to have some of our staff just talk a little bit about these issues. Hang on. Can you hear that?
No, you might have to select share sound as well.
All right, just a moment. How do I do that? Share sound. Let's see. Okay, I will do that one more time.
Here in Kalihi Valley, we're just 10 or 15 minutes out of main downtown Honolulu. It's a very different area. A lot of the families are lower income. Most people are working 2 jobs. And so we have a lot of children whose families aren't home to cook dinner every night. And so it's a package of ramen or it's something really fast.
It's not easy to live healthy here. Kalihi in particular, it does not have access to fresh fruits and vegetables. On an island this abundant, like that's ridiculous.
And to
So just, I'm going to go through quickly, about our health center, Kalihi Valley. We were started in 1972. We're about 50 years old. Got our, we became Fqhc in the 1980s. And today we're celebrating 50 years. So we take care of a lot of patients, primarily Asian Pacific Islanders, as we talked about earlier. And generally, a lot of our patients live in public housing. So this is one of the largest, or the largest public housing project here in the state of Hawaii. The Kahio Park Terrace are two large apartment buildings that you can see oftentimes when you're coming out of the airport or driving down the highway. But I'd say about 40% of our patients live in public housing. So what are we doing? This is kind of what you guys are all here for. What are we doing to prevent diabetes? Well, it is the overwhelming scourge of the for our patients in the community, along with its relatives, all the other chronic diseases that are associated, lifestyle diseases, our social diseases. Yeah. So let me share another talk about what we're doing.
And so KKV was founded because we believe that ancestral connection is what makes that sense of abundance, that makes our wholeness, which makes our health. Kokua Kalihi Valley is a 45-year-old nonprofit, and while we are a federally qualified health center, we started our work here going door-to-door listening, asking the community, what do you really need? And we realized that you cannot treat health and food systems with just medical intervention. We have to treat the whole community, the whole family.
So certainly there's a lot written in the literature about preventing diabetes, diabetes prevention programs, and talk a little bit about what we're doing. So our approach is based upon discussions of the community and what they see as health. So, out of these discussions, we have a framework for health, connection to the past, present, to have kuleana, a better purpose in the world, a connection to place, to have kinship with the land, a connection to your better self, and a connection to others, to be loved, to love, to be loved, and to understand and to be understood. We have a plethora of community programs focused around improving the health of the community. There are several that are kind of relevant to the purpose of diabetes prevention. I'll go through those briefly. I wanted to just go back before moving on to our prevention programs, is to kind of give a foundation or a thought about why we focus on community and in terms of diabetes prevention. So, in preparation for this talk, I came across this article. We really focus a lot on our community health programs in terms of our prevention. But I think this was a study that kind of caught my attention and seemed to speak to what we do. There was some might describe as a social experiment run in the 1994 to 1998 by the Department of Housing and Urban Development. And they looked at what they wanted to do was to look at the effect of neighborhoods and communities on health. And so they had a group of folks that were living in public housing, about 4,000 people living in public housing. For this particular study, they looked primarily at the women and children, and so they were giving out rental assistance vouchers, and so they decided we have only a limited amount of these things, and we're going to look and see what the effect is of the vouchers, in particular what the effect is of moving somebody from public housing to an area of low poverty, what that would do to their health. So they randomized 3 groups. One group got a low poverty voucher, a voucher that moved them to an area with low poverty, and they got another group with just a standard housing voucher, and then another group that didn't get any voucher at all, stayed in public housing. And these groups were there. They had the rental assistance vouchers for 1 year, and so they were kind of required to those that got to move to the low poverty area had to stay there for 1 year, and then they could do whatever they want after that. And what they found that after 10, 15 years, they looked, I'm sorry, take a step back. So there was an analysis done and published in the New England Journal in 2011, Ludwig and our associates, looking at neighborhoods, obesity, and diabetes. And they looked to see what happened. They looked at the baseline measurements of obesity, BMI. They looked at the baseline measurement of A1C to get a sense of what happened for those that participated in this study. What they found was the folks that moved from the folks that were randomized to receive the low poverty vouchers and moved to low poverty areas had significantly lower rates of severe diabetes and extremely lower rates of A1Cs above 6.5. So it doesn't point to one particular thing, but it does speak to the importance of community to neighborhood and determining somebody's health. So I think we really focus around that idea at KKV. And I think there's good evidence, a good support for this idea and concept. One of the programs we have is the Kalihi Valley Instructional Bike Exchange. We take kids. It was born out of a grant to promote physical activity in communities with high rates of diabetes. And they take kids and they teach them how to fix bikes. and they teach them about issues of social justice and they promote a healthy lifestyle. A lot of kids have been through it. Around that issue of learning about social justice, you know, they learn about neighborhoods, they learn about equity. And one of the things that they happened upon was that there was a big thoroughfare, essentially connecting two highways, one coming through the mountain from the wealthier parts of the island, connecting down to another interstate, the main interstate H1. And it oftentimes a really busy, previously had been a really busy 4-lane road, and they had heard that they were going to be repaving the road. So the kids and the organization got involved and attended city planning meetings and advocated for a better approach to the road. And so nowadays, if you go there, you can see the fruits of that advocacy. It's now one lane in each direction, and a bike path as well, and a much safer street and a better, more conducive place for healthy living for the residents that live in that area. We have an elderly exercise program. We have a roots food program that we connect patients living in public housing to healthier foods, more traditional foods that they would have. So just recently, this past Thanksgiving, I mean, they come in every week to come in and pick up their breadfruit, but what struck me this past Thanksgiving was they were all lined up just to pick up their breadfruit, and this is something that happens on a weekly basis. Part of their program, they provide packs of produce for patients that are at risk for diabetes. Family members can come pick up their packs of produce, and they have a farmers market. A lot of these things that you might, farmers market, food hubs, these things you might find in wealthier neighborhoods. So we try to recreate that within our community. We have a nature preserve that sits in the back of the valley. I'm going to end. Do we have a little bit of time? I have about three more minutes just to kind of show you a little bit about the valley and the preserve and the work that they do.
Here at KKV, we bring culture into all of the things that we do. We have a family health program where we recruit kids 3rd to 5th grade, and we use all Native Hawaiian philosophy and values. Most of these kids that are living in our public housing or apartments, they've never seen a carrot come out of the ground. They've never seen a pineapple grow on a bush. We teach them how to grow healthy foods, how to prepare healthy foods, and that our food is something to be honored.
We hold classes through Kalihi for pregnant women to birth in a way that our ancestors did, teaching them that you want to eat fish bones to get calcium, that you need to eat the leaf of the kalo plant. So the new growth is coming out? Okay. When we teach that is what the wahine needs to eat, then that plant needs to be available. So in that sense, it strengthens our community by strengthening our connection to the land and our culture.
So I'm Vali Tatofi, and I live just down the road. Through a family, I learned about a program up here, and they would invite people, come up here, you can work the land, you can grow your food, you can take the food with you. I started to see how to eat healthy and be healthy. And so they really opened up a lot of awareness for me and for my kids, because I want my kids to be rooted. I want them to be grounded. I want them to know who they are, where they're going. Because I never got to know that before, I would never want to go into anyone else's community and say, this is how you can make your community healthier. But what I can say is that in this place, I'm witnessing health, I'm witnessing growth, witnessing transformation. My hope in the long term is that this 100 acres is a place where people coming together to grow food is what we see as health. Children learning to make art and learn from elders. That's what we see as health. We have to see all the parts of community as health.
Okay, so I think that is where I will leave it. You know, diabetes, we have a plethora. We do a traditional diabetes prevention program, you know, where we focus on intensive lifestyle counseling. But I think the biggest, the most amazing programs that we have around diabetes prevention are community health programs. And I think that preventing or working in diabetes prevention, it doesn't have to be a burden. It can be a real joy. And I think the programs that we have at KKV kind of speak to that. So thank you very much.
Thank you, Dr. Tan. We do have a, sorry, we do have a couple of questions that came through, and I would love to just sort of ask you those questions and see if you can respond. And if folks have other questions, please put them into the Q&A. But one question here is to asking if you still see many patients that are affected by the fallout of nuclear testing on the Marshall Islands. So how has the long ago poisoning of residents impacted health outcomes, including diabetes? Is that something you can speak to?
Yeah, you know, I in my training, I had an opportunity to spend some time and work in the Marshall Islands, and in particular, I think the work that, or the grant that brought us out to the Marshall Islands was funded to support and care for patients that were affected by the nuclear testing in the Marshalls. At our clinic, Kalihi Valley, our biggest group is our Fqhc patients, and they're from a different part of Micronesia. So they're a different country entirely. So they're from the Federated States of Micronesia, and for them, you know, I really separated quite far geographically from the nuclear testing. We haven't focused a lot of our efforts to focus on, you know, were there any effects from the nuclear testing. But I know within the larger health community, you know, there is groups that are working on that.
Thank you. And thanks for that question, Bonnie. Another question we have here is, someone would like to know your approach when you meet with patients to discuss about diabetes and management, or, you know, pre-diabetes and management. Is your focus on nutrition, lifestyle, or medication driven?
My particular approach?
I would say your particular approach, and then maybe.
Yeah. I think my particular approach, just generally speaking about working with patients is, you know, actually I invest, when I first meet a patient, I invest a lot of time to get to know them, to know who they are, to know where they're from, what their life is like, and think about how that might impact their health. And it's not intuitive. It's not the way I was trained, I would say, going through modern medicine. We kind of focused upon, you know, okay, well, this patient is here for hypertension or diabetes, and kind of focus on that. But I found, working at a community health center and learning from people that are much smarter than me, that you know, to think about who they are and where they live, what their life is. It informs in a path forward. So yes, so that's where I start, and then you know, then I think about, you know, what is going to be setting them up for diabetes. You know, so for example, our Micronesian patients, a lot of them live in really desperate life circumstances. You know, I have one patient, they live in a family of 4. There's one person in that family who is a breadwinner. They work at McDonald's, and everybody except, you know, 1 or 2 people in that family has diabetes, you know, and they worry about every day having enough food. And as a whole, they're generally excluded generally excluded from social safety net programs like food stamps. And so what they earn is what they're going to use to buy their food. And so it's really hard to counsel and work with somebody without knowing about their life situation, about okay, well, what I'm going to talk about with food. You know, they tell me they purchase a bag of rice because it's the most affordable, you know, form of food, you know, or they purchase chicken, and that's pretty much what they eat, you know. And how do I discuss, okay, well, I want you to think about a more balanced diet. And well, I can only do that if I know who they are, where they live, you know, what life they live, what their resources are, where they're coming from. And so that's where I start. And then I connect them. You know, we have these programs like the Food Hub, we have packs of produce. So then I'll say, okay, well, you know, since you what your family has is one income from working at McDonald's, I'm going to try to connect you with our packs of produce program. I'm going to try to connect you with our park in the back of the valley and get you a chance to go out and work there sometime if you like.
Yeah, thank you, Dr. Tan. I think Carolina, who asked that question, said, you know, that's excellent, excellent approach, and she tries to do the same. So that's wonderful to hear. I think one of the things that struck me as you were speaking is that it's a very patient-centered, family-centered way to approach the work, where you know, when we talk about sort of anti-racism, for example, part of what's a challenge is sort of the modern medicine and our healthcare system says, well, we'll just tell patients what to do, and we know we have all the answers, and we'll give them, you know, all this information. But really, what you're sort of speaking to is actually letting the patient tell you what is the most impactful and meaningful for them. And I love that idea of incorporating their goals and what's meaningful to them and into that care. I think that's really exciting and something great to hear about. So Jocelyn has a question here saying, I'm happy to see gardening, cooking, and produce programs in place at your FQHC. How much emphasis does your FQHC place on plant-based eating to reduce the risk and severity of diabetes?
Yeah, I would say we place a lot.
Mm-hmm.
You know, we really encourage you know, plant-based diet by, you know, in all aspects, and try to get patients involved not only in the consumption but in the production of plants that they can eat. I think it's really important. We have a large section of our staff employed around these programs and work around these issues, and make it a priority.
Yeah, absolutely. I guess to sort of counter that in a way, do you find that your patients, is there sort of culturally preferences for certain, you know, culinary foods or things that maybe aren't plant-based, and allowing that to be also part of the equation, be sort of listening to what's kind of accepted in their culture and what kind of food they like to eat as a community?
Yeah, no, absolutely. You know, like, I remember one comment about, you know, a comment from our patients was like, you know, saying like, it's not in our culture to eat a lot of vegetables. And I mean, but the follow on from that was like, you know, having these programs available, you know, like this was a comment from their packs of produce program, I believe, or one of the associated programs was like, you know, it's not in our culture to eat vegetables, but you know, it was made there's so much abundance in that, and over time it became like, you know, like this is something really great, you know, it is now part of what we do, you know, and we find it a really valuable for us. But I do think, yeah, it's important to listen. I mean, so they, you know, a lot of our patients like to eat fish, you know, and back from from the island communities that they come from or are part of. And different places, it's much easier to get fresh fish, you know. You could get it at a convenience store that, you know, now the convenience stores that they have access to, they don't have fresh fish. They have, you know, canned meat. So, but then, you know, our programs that, you know, they'll teach them like, okay, well, you know, you can get reasonably priced frozen fish that you might be able to afford and incorporate that into your diet. And that would be a healthier choice for you than getting a you know, a pack of canned meat, you know.
Right, absolutely. Great, thanks for expanding on that as well. I want to actually invite Dr. Washington to the table here as well to kind of answer some questions. So Dr. Washington, if you want to kind of unmute, I know you're not on video, but that's totally fine. I just had a question that kind of is for both of you here in the chat, and it's, what are the differences that you see when a health center effectively addresses the needs and social factors affecting their patients' health, and in particular, their patients of color? So I know that's a lengthy question, but what are the differences you see when a health center, you know, approaches that and is effective with that?
Well, from my perspective, and I do live. I work in an acute care setting and we have community health centers. And I think the difference in the acute care setting approach and the community health center approach is the more personal involvement, the more taking by the hand and navigating the system in terms of problem solving that happens in community health centers compared to that kind of help offered in the acute care setting. The community health center staff know the neighborhood, know the people who live in the community, know where to get the preferred food. Do you go to Stop and Shop or do you go to Market Basket? And that encourages people to, I don't want to use the word adhere. It encourages people to engage more in the care planning and the education that they're given when they come for a visit.
And Dr. Washington, just to, you know, to that point, do you sort of see a connection? Because I do see this as that's a connection between sort of combating or taking steps to combat sort of that institutional racism, or that the sort of systems that you talked about earlier in your presentation, you know, that ability to actually connect with individuals in the community is do you see that as part of kind of that anti-racist or that, you know, equity framework?
Yeah, part of the solution is it upsets me that people of color continue to be sicker than other populations. And that's intolerable to me. So the charge is, how do you create change? People can't simply be on the receiving end of limitations.
Right.
We have to be able to participate. So connecting with healthcare providers who share the same ethnicities, share the same culture, which is what you'll find more often in community health centers, helps us to engage with the system, even if it's a small step, in ways that enable us to make change, and change is what's needed.
Absolutely. Dr. Tan, anything you'd like to add to that question or Dr. Washington's points?
I'm sorry, can you refocus?
Sure. Yeah,
I was looking at the chat there for a brief second here.
Yeah. So what are the differences, or, you know, what benefits do you see when a health center addresses the needs of social factors that affect their patients?
Well, yeah, I mean, for me, I think it's the driver of health in our community, the social factors, and including, you know, this issue of racism that Dr. Washington speaks about. You know, didn't talk about it much, but I think, you know, even racism is an important thing that we think about. But yeah, to address the social factors, that's what it's about. If you want to move the community to a healthier place, I think it's important. That's where the biggest return is.
Absolutely. Thank you both. We did have one other question come in from Shannon, and maybe this is for you, Dr. Tan. How have you targeted increasing self-efficacy in diabetes in racially diverse populations?
Yeah, so I'm trying to think in terms of increasing self-efficacy. So meaning, let me just make sure I just use simple words. So
yeah, I know.
yeah, so increasing their ability to be yeah. So I think the idea of increasing self-efficacy is this idea of not just drilling down into the really small narrow approach to diabetes, but it's like in a larger context of culture that the organization embraces, and some of and looking at the root causes, including things like racism. You know, like Dr. Washington points out, and so we try to create the conditions in the lives of the patients where it's easy to have a healthy life, so that we're not seeing these amputations like Dr. Washington points out. You know, that one group of people is not facing this disproportionately, and we see that in Hawaii. We see that in the communities that we serve.
Yeah, thanks for that. I love that idea of dismantling the systems that inhibit that ability to live according to what their goals or what they want for their lives. And in fact, I think that's a really beautiful way to speak to that. Wonderful. So I'm going to turn it back over to Sakura, who's going to wrap us up and give us some resources. Thank you both for answering those questions.
Thank you, Dr. Tan. Thank you, Dr. Washington, for answering very complex questions within a short matter of time. Before we close, I just want to share some resources that we have. Albert will also include these in the chat box. Related to diabetes awareness, and pre-diabetes. And then this is the ProPublica reading that Dr. Washington had mentioned earlier. And then what are some next steps? So there is a link to identify some national DPP providers in your area. And we also have our own resources. So NNCC and the Health Promotion Council will have a peer-led series exploring promising practices for health centers implementing or interested in implementing the National Diabetes Prevention Program. And the December session is going to come up on December 8th, 2021 at 3 p.m. Eastern Standard Time. And we're going to drop the link again in the chat box, so feel free to check it out and register. And then AAPCHO will have our own webinar as well on language access at community health centers. And we are partnering with Farm Worker Justice, a fellow national training and technical assistant partner, to host a webinar focused on language access at community health centers. Please join us to learn about the challenges, promising practices, and innovations in language access amidst the COVID-19 pandemic. This webinar will be on December 16th at 9 a.m. Hawaiian time, 11 a.m. Pacific time, and 2 p.m. Eastern time. And again, we'll also drop the link for this as well. And with that, thank you so much, folks, and feel free to fill out the survey when you are done. Thank you, folks. Take care.
Thanks, everybody.
Thank you, Dr. Washington. Thank you, Dr. Tan.
Thanks, Dr. Washington.